Thank you to the organizers for inviting me to be a part of this event. I'm Jennifer Fang, neonatologist at Mayo Clinic. I serve as medical director for our teleneonatology program. I'm excited for the opportunity to share with all of you how we use telemedicine to support neonatal resuscitations and our experience in using telemedicine to really change the standard of care for our patient population. I do have one disclosure, which is that I have licensed IP and can earn royalties from Teladoc Health, and I also own stock in the company. So over the next 30 minutes or so, I want to start by providing you with a bit of background as to why we developed our teleneonatology program, really recognizing that there were system level challenges to healthcare delivery for neonates. And this is why we thought about introducing telemedicine. Then I'll share with you the data that we've been collecting on the impact of telemedicine on newborn access to care, triage, patient safety, and the quality of care. Because when I think about shifting the standard of care for our patients, we really need to have evidence that the change is providing value to our patients and families. And then lastly, I'll step back and look beyond Mayo Clinic and share with you the results of a study that we recently completed that evaluated the perceptions of providers in both NICUs and community hospitals on the use of teleneonatology in their practice. I thought it might be helpful to start by providing you with a little bit of background on Mayo Clinic. So this is a picture of part of our campus at the Mayo Clinic Hospital in Rochester, Minnesota. And this is about what it looks like right now. Nice kind of spring, early summer day. So Mayo Clinic is a large organization. Our main campus and our academic medical center is here in Rochester, Minnesota. We have nearly 2,400 physicians and scientists who provide care to about 400,000 patients annually. We also have a campus in Arizona as well as Florida. Relevant to my presentation today is that Mayo Clinic also has a health system that includes 18 community hospitals in a 3-state region. So these are smaller community hospitals in Minnesota, Wisconsin, and Iowa that are part of Mayo Clinic. And it's these community hospitals that we actually provide our teleneonatology services to. I also just wanted to take a moment to mention Mayo Clinic's Center for Digital Health. So this center within Mayo Clinic is kind of been tasked with or has a mission of translating the Mayo Clinic approach to care into digital experiences everywhere. And this includes optimizing the patient and provider journeys, orchestrating workflows, and really blending the virtual and in-person experiences and resources. And within the Center for Digital Health is our Center for Connected Care, which includes all of our virtual health services, part of which are those synchronous or live video services such as teleneonatology, and also includes our asynchronous services and remote patient monitoring. I mentioned the Center for Connected Care and the Center for Digital Health because they provide a lot of those virtual health services and support that have been important as we developed, implemented, and have now expanded our program. So with that, I want to go ahead and move into a little bit more about neonatology and the system level challenges that existed to optimal neonatal resuscitation in smaller community hospitals. I thought it might be helpful to go ahead and start with an example of a patient story. So if we think about the resuscitation of, for example, an extremely preterm baby in a small community hospital, this presents quite a challenge. The physician and care team there, they don't frequently resuscitate extremely preterm babies. that this is a high acuity, stressful, high complexity type of resuscitation. And so when this would happen before telemedicine, they'd gather their team, they'd prepare their supplies, and they may call the neonatologist at the nearest NICU to say, hey, I'm expecting this extremely preterm baby. Can you dispatch your transport team, because I know this baby is going to need to be transferred to the NICU, and are there any words of wisdom you can provide for us as we're about to perform this resuscitation? And the neonatologist, may provide some general guidance about, okay, breathing for the baby and thermoregulation. But what care the neonatologist could provide was quite limited. Now, whereas you can imagine this scenario happens quite differently if the neonatologist can connect with this care team via video telemedicine. Now, instead, the neonatologist can be present virtually and can prepare with the team prior to the baby being delivered. And when that extremely preterm baby is born, can actually guide the team through the resuscitation and helping that baby breathe, providing supplemental oxygen, securing vascular access, getting the right lab so that baby is stabilized and in a good clinical condition when the transport team arrives. It's really a very different way of delivering care. And as you think about it, a very impactful way to improve upon the current standard of care. Now, I share this because it is an example of an actual clinical consult that one of my colleagues provided. We had a little baby girl, Haley, who was born at 26 weeks in a small community hospital. And my colleague, neonatologist, partnered with the pediatrician there to help Haley breathe, to make sure she remained warm during the resuscitation, to place that vascular catheter into the umbilical cord vessels so we could send blood samples and provide medications and fluids. And then Haley came to our NICU, spent a couple of months with us, and she did very well in the NICU. And she continues to do well since being home with her mom and dad. So great story. Now, instead of just focusing on a single patient, let's look at what does the evidence show us about how we're performing when it comes to these high-risk babies being born in community hospitals. Now, first of all, obviously, this is not what we want to have happen. Ideally, the high-risk deliveries and our preterm babies are born in a hospital with a NICU. But in reality, this is not always achievable. So if you look at this map of the United States, for example, which is showing the distance to a neonatologist, you can see that in the center part of our country where we have expansive geography and a lot of rural hospitals, the distance to a neonatologist is quite long. And so these patients practically can't get to a hospital with a NICU. In addition, emergency situations occur. There may be a maternal emergency or a fetal emergency that means that baby needs to deliver right away in the community hospital. So what happens to these babies when that happens? Well, what the evidence shows is that when these high-risk neonates, particularly our preterm or very low birth weights, are born in a hospital without a NICU, they experience higher rates of mortality as well as serious morbidity. And this has been shown in North America, Europe, Australia, New Zealand. We know that this happens. So there really is a gap in the care we're providing and an outcome disparity that we need to improve upon. And if we think about this from the perspective of our colleagues in these community hospitals, our pediatricians, our family physicians, they are really charged with a very difficult task that they don't experience or do not have to perform these types of resuscitations frequently. And we know based on the evidence that while our providers are trained in neonatal resuscitation, these skills sharply decline in a matter of months after training. And the fact is, they just don't do this frequently. When you survey providers in rural hospitals, they will say that they ventilate a neonate maybe 1, 2, or 3 times a year. Yet achieving effective ventilation is the most critical task during newborn resuscitation. So again, I think, this difficulty in establishing and maintaining proficiency in these high acuity cases is really very difficult. And so we asked ourselves, knowing what we know about the outcomes for these babies and the challenges that rural providers face, how do we improve upon this system? How do we improve upon the current standard of care? Well, now we have telemedicine. We have a new technology, a new product that allows us to diffuse that neonatal resuscitation expertise and experience out to these community hospitals. So we asked ourselves, can we use telemedicine to close this gap in the type of care we're providing and the outcomes that we're seeing for these neonates? So I want to take a moment to acknowledge that whenever you change a system, it is not easy, that we need to recognize that our desire to change must be greater than our willingness or our desire to remain the same. And I think for our practice, we reviewed the literature. We were very familiar with these differences in outcomes for babies born in community hospitals. And as neonatologists, I think we've all experienced cases where we have a baby, who was born in an outside hospital, and that care team did the very best they could to care for that baby. Yet when that patient arrived to the NICU, we were really worried about the outcome for this patient, and we wondered, what more could we do for this baby? And so it's all of that that really prompted us to develop our teleneonatology program. And now, again, this is a network that allows our neonatologists to establish a real-time audio-video connection with our pediatricians, our family physicians, our nurses, so we can provide a higher level of support when newborns require critical care. Our program's now about 8 years old, and we've done this over 600 times. To provide you with a little more context, the Mayo Clinic Hospital here in Rochester, we have 2 neonatal intensive care units. We have a 34-bed level 4 regional NICU, which is where we care for our extremely preterm babies, our neonates that require surgery or ECMO. We also have a 24-bed level 3 NICU. It's our 9 neonatologists that staff these NICUs that also provide our telemedicine consultations. Our program has grown over the last 8 years. We currently support a total of 19 community hospitals in a 2-state region. Most of these you can see are part of that Mayo Clinic health system, but we also provide consultation to 2 external hospitals. And altogether, our program serves 7,000 or is available to 7,000 deliveries each year. Now, what type of care are we providing via telemedicine? Well, this is an acute care telemedicine program. Again, we're resuscitating, stabilizing, and providing critical care. So these might be babies who have respiratory distress, who are born prematurely, or who require advanced resuscitation, or where there might be concern for brain injury after delivery. And we're helping guide interventions, recommending therapeutics for these patients via telemedicine. Now, before I get any further into the presentation, I thought it might be helpful to share with you a video of a simulated teleneonatology consult so you can really get a feel for the type of care we're providing.
Mayo Clinic Admission and Transfer Center, this is Chad RN. How can I help you?
Hi Chad, this is Julie. I need an emergency telemedicine consult for a preterm infant going to be born in Austin.
Okay. I just sent the page to our neonatologist, and I need to confirm you're calling from MCHS Austin, right?
Yes.
And briefly, what's happening with the baby?
We have a 28-week infant that will be born soon.
Okay. So, and that's our physician calling here. Let me put you on hold, and I'm going to get us connected, okay?
Okay.
ATC, this is Chad.
Hey, Chad, this is Bill Carey from Neonatology.
Say, I have Austin on the line. They have a 28-weeker that's not been born yet, and they want a teleneo conference. Can I connect you?
Yes, please. Thank you.
Okay. Go ahead, Dr. Carey on the line.
Hey, this is Bill Carey. I'm a neonatologist in Rochester. I understand you have a telemedicine consult for a 28-weeker.
Yes.
Okay, great. Hey, Chad, can you do me a favor and dispatch the neonate team down to Austin, and I'll connect via telemedicine right now.
Okay. Will do.
Thank you. I'm going to stay on the line here until I'm connected, and I am live on video.
Yes, we have you on video.
Okay, thank you.
Thank you.
Hi, I'm Bill Carey. I'm one of the neonatologists at Mayo Clinic Rochester. Can you introduce yourself so I can understand who's on the team today?
Sure. I'm Dr. Fang, the pediatrician, and I have 2 nurses on my team today.
I'm Julie.
I'm Lindsay.
Great. Good to meet you. I understand you have a 28-week baby on the way.
Yeah, that's right. And we're just getting everything ready. We have our chemical mattress and plastic wrap. We have our neo wrap set and ready to go. And I have intubation supply should I need it.
That's perfect.
Okay, great. Anything else? Because I think baby's about to deliver.
No, I'll go tend to baby.
Okay, all right. Okay, baby's out. Okay, we'll lift baby. Okay, we'll get monitors on. Baby's looking pretty apneic.
What's that monitor on here?
We're just stimulating.
Looks like you're doing a good job of that. Still apneic.
Yep, still apneic.
Julie, can you check the baby's heart rate for me quickly?
Sure.
And
Heart rate 70.
Okay, it seems like the baby is apneic, so Dr. Fang, if you could please provide some positive pressure ventilation, that would be great.
It looks like, if you could please, tilt the chin back a little bit. Tilt the
Okay.
head back and lift the chin. There you go. That'll help with air entry.
Yep, our manometer is looking much better now. Thank you.
And why don't you breathe a little bit more quickly than you're doing right now? So maybe
Okay.
50 to 60 times a minute.
2, 3,
1
breathe.
minute.
2, 3, breathe. 2, 3, breathe. 2,
How's
3.
the heart rate, Julie?
Heart rate's still 70.
Fine. I'm not seeing very good chest rise right now, so Lindsay, can you
That's
increase the peak
true.
inspiratory pressure up to 25 for me? How does
Okay,
that feel, Dr. Fang?
we're up to peak of 25, and the chest rise looks much better. I don't know if you can see that.
No, I can. It looks
But
good from
it-
here. I just wanted to get your take on it.
Yep, it looks much
That's
better.
great. How's the heart rate, Julie?
Heart rate's still 70.
Huh. How are the saturations?
They're 60.
Okay. Lindsay, if you could please dial up the FiO2 to 40%, and we'll see if that helps improve the heart rate.
Okay, we're there.
Yeah, and baby looks like baby's doing some breathing on his own.
Okay.
Heart rate's greater than
Saturations now,
100.
Lindsay?
They're at 72.
Okay, so coming
Okay.
up.
Yep,
And spontaneous breathing
It's-
looks like it's starting to happen. Kind of intermittent.
it is. It is. Yep, and Julie said our heart rate was greater than 100, so I think baby seems to be
Right.
responding.
Excellent. Yeah, do you want to try some CPAP alone for right now?
I think
Keep our
so.
FiO2 where it is? Okay,
Yeah,
great.
let's try that.
Thanks for getting the temperature, Julie.
Oh, you're welcome. It's 37.2.
Perfect.
And
So it
baby's
looks like the
breathing.
Baby's breathing pretty well.
Yeah. Yep.
Excellent. Saturations, Lindsay?
80.
That's great. They're moving in the right direction. Heart rate?
Heart rate's still greater than 100.
That's excellent.
And we're almost 3 minutes old, Dr. Carey.
Okay, perfect. So, look, I just got a page from our transport team. They're about 20 minutes out. Maybe one thing to do at this point would be to check a blood sugar, and if you can, place an IV to start some dextrose fluids. Does that seem like a good idea?
Yeah, I think we can do that. Thank you. Baby's still breathing well.
Perfect.
Great.
So I hope that video helped you get a sense of, again, the type of care that we're able to provide via telemedicine for these newborns. Now, when I think about how telemedicine really changes the care we provide and may be able to shift the standard of care, I think about how it facilitates assessment of the patient and what we're able to do with guiding the appropriate interventions. So when I think about remote newborn assessment, what telemedicine offers is huge, and it's the ability to visually assess the newborn. This isn't something we could do via telemedicine. So when I connect, I can see the baby. I can see, are they breathing on their own? Are they working hard to breathe? Are they breathing fast? What's their, tone, posture? How responsive are they? All of these things that can help as we, move through the resuscitation and our clinical decision making. If needed, I can auscultate the heart and lungs. And importantly, too, I am present with that team. I can observe what they're doing, listen to what they're saying, what they're thinking, so we can have such a deeper partnership and collaboration in the care of the patient. There are a couple unique challenges when we think about teleneonatology, one of which is our patients are small, that we have small patients surrounded by multiple adult care team members. And this is important simply because we need to think about this when we select our telemedicine product. And in addition, while we can visually assess the baby via telemedicine, obviously it's not the same as in person, that I can't touch the patient, palpate the patient, or actually perform the procedures myself. So a big improvement upon being on the telephone, but still, not quite the same as being in person. Now, if we think about telemedicine and our ability to guide care and thinking about the interventions a baby might need, again, as you saw in that video, we can really lead that team and coach that team step by step through the resuscitation. And we can help with things like selecting equipment, like what size ET tube should they use for the baby. Medication administration, we can ensure weight appropriate doses. As we're moving through the consultation, we can, prompt them, okay, now we need a chest x-ray, or we need to make sure, we check a blood gas here in the next, few minutes. And additionally, we found a lot of value in being able to speak with the parents or caregivers via telemedicine, particularly when we know this baby needs transfer to the NICU. We can share with them what's happened during the resuscitation and what they can expect when the baby comes to the NICU and when they arrive to the NICU to be with their baby. So now I want to move forward with sharing with you the data that we have on how telemedicine improves the value of care. Again, because I think this is so central to successfully being able to shift the standard of care that we need to demonstrate value. So first and foremost, from my perspective, our program has been about improving equity in access to care. So this is a map of that Mayo Clinic Midwest region where those red numbers are the number of babies born at each of the sites. And when we were thinking about the neonates born in our Mayo Clinic Midwest region before we had telemedicine, less than half of these patients had immediate access to a neonatologist if needed. It was only those babies born at Mayo Clinic Hospital in Rochester, Minnesota. Whereas now that we've fully implemented our teleneonatology program, we can now say that 100% of babies, any baby born in our Mayo Clinic Midwest region, has immediate access to a neonatologist if needed. That through telemedicine, I can connect to a baby that was born, 150 miles from here and help that team care for that critically ill baby. Telemedicine has also been helpful in facilitating efficient, effective, and safe patient triage. That again, that ability to visually assess the patient and work collaboratively with that care team has been really useful. So when we look at all the patients who have received a telemedicine consult, about 1 in 3 of these neonates is able to remain in the birth hospital following the consult, which again is most important for the baby and the parents, that we can keep them together and we avoid separating the newborn from the mother and father. In addition, it's helpful because we're avoiding unnecessary medical transport, which obviously has implications for cost of care. When we look at the comparative and get access to a neonatologist if needed, that through telemedicine, I can connect to a baby that was born, 150 miles from here and help that team care for that critically ill baby. Telemedicine has also been helpful in facilitating efficient, effective, and safe patient triage. That again, that ability to visually assess the patient and work collaboratively with that care team has been really useful. So when we look at all the patients who have received a telemedicine consult, about 1 in 3 of these neonates is able to remain in the birth hospital following the consult, which again is most important for the baby and the parents, that we can keep them together and we avoid separating the newborn from the mother and father. In addition, it's helpful because we're avoiding unnecessary medical transport, which obviously has implications for cost of care. When we look at the comparative analyses that have been done by other neonatal telemedicine programs in the US, what they have found is that telemedicine reduces the odds of transfer by about 30 to 50%. So again, quite a big reduction in odds of transfer. We've also been monitoring the impact of telemedicine on patient safety. And for this, we've been following our frequency of settled birth injury cases. So before we had teleneonatology, when we looked at all of those hospitals in the Mayo Clinic health system, what we found was that on average, we had a settled birth injury case about every 7 to 8 months. However, since implementing telemedicine, we haven't had a single settled birth injury case in over 8.5 years, which is the longest period of time we've gone without a birth injury case in over 15 years. So it seems as though by having that neonatologist present virtually, by bringing their additional expertise, experience, and leadership to these stressful, high acuity resuscitations, we're able to ensure that these babies are receiving the standard of care and the highest quality care that we can. And the last metric I want to touch on is the quality of care, specifically the quality of newborn resuscitation. So this is a retrospective cohort study that we published now about 3 years ago, where we looked at these outborn or these at-risk neonates born in community hospitals that were subsequently admitted to our NICU. And we compared the quality of the resuscitation between neonates who received a telemedicine consult and matched controls that did not. And the quality of the resuscitation was rated on a 1 to 10 scale, where 1 was a poor quality resuscitation and 10 was an excellent or high quality resuscitation. And what we found was that telemedicine consultation did significantly improve the quality of these resuscitations. And you can see here that the median quality rating was 7 in the telemedicine group compared to 4 in the control group. And if you look here on this graph, the percentage of babies that received a high quality rating or a rating of 5 or higher, you can see it was much more in the telemedicine group. So 55% of patients in the telemedicine group versus 30% in the control group. And when we did a time sensitivity analysis and restricted the comparison to those where the consult was provided within the first hour of birth, or that golden hour, as we call it in neonatology, what we found was now that median quality rating was even higher in the telemedicine group. So you can see that median quality rating of 8, and the median difference between the two groups was also greater. And again, the difference in the percentage of neonates that receive that high quality rating was even more significant. Now, as we think about changing the models of healthcare delivery, I think it's really important that we measure how the users are experiencing this new healthcare delivery model. And we do this with our program where we survey both the community hospital physicians and the neonatologists after our telemedicine consultations. And what we found has been very positive, that our community hospital care teams use the service and they recommend its use to their colleagues, that they feel that the remote neonatologist is working collaboratively with them, that we're sharing information and not just kind of delivering recommendations, but also seeking information from them as the community hospital care team that is with the patient. Similarly, the neonatologist experience with telemedicine has also been very positive. They feel like through telemedicine, they are achieving that shared mental model during the resuscitation, which is so important, that they're getting that briefing when they join the team virtually, that again, information sharing is happening very well. And even though they're not in person at the bedside, they still feel like a member of that care team when they're connected via telemedicine. So the last thing I want to do is, again, kind of take a step back, look outside and beyond Mayo Clinic, and think about how are other NICUs, how are other community hospitals perceiving teleneonatology? You know, as we're thinking about, are we on the verge of changing the standard of care, doing an assessment of these perceptions? So this is a survey that we completed last year where we reached out to 5 NICUs and 27 community hospitals in the US and Canada that were not currently providing or receiving telemedicine services. And we used validated implementation science measures to evaluate these perceptions of teleneonatology, specifically their perceptions on the acceptability, appropriateness, and feasibility of teleneonatology. Now, these 3 measures each had 4 statements, so it was a total of 12 statements that the respondent would agree or disagree to on a 1 to 5 scale, where 1 was strongly disagree and 5 was strongly agree. And so you can see we had a survey response rate of 56%, which included 203 responses from these NICU and community hospital sites. So what did we find? So first, let's look at how they evaluated the acceptability of teleneonatology. So does teleneonatology meet their approval? Is it appealing to them? Do they like it? Do they welcome it? Well, if you look at the percent of respondents that agreed to these statements, it was anywhere from 88 to 98% with a mean rating of 4.5 to 4.7. So very positive perceptions of the acceptability of teleneonatology. Now let's move on to appropriateness. Does teleneonatology seem appropriate for their practice? Does it seem fitting, suitable, applicable, like a good match? Again, very positive, high levels of agreement, 93 to 97%, mean ratings of 4.6 to 4.7 when looking at perceptions of appropriateness. Now, lastly, feasibility. Does teleneonatology seem implementable, possible, doable, easy to use in their practice? Again, 88 to 98% of respondents agreed to these statements with mean ratings anywhere from 4.4 to 4.6. So what does this mean? From my perspective, I think we can take away that there really seems to be very broadly positive perception of teleneonatology, both in NICUs and community hospitals. And when we looked at the data, we did not see differences, between NICUs and community hospitals. We didn't see differences based on years of experience in neonatal care. We did not see differences depending on how long the provider had used telemedicine, if they had used it at all. So again, it really seems to be that people are very open and curious and positive about the use of telemedicine for newborn resuscitation, which obviously I think is really exciting. So in conclusion, I hope I was able to effectively share with you what it was about the system level challenges and the outcome disparities for these at-risk newborns that really prompted us and led us to develop our teleneonatology program. And that we found that through telemedicine, we can improve access to our neonatologists, facilitate safe patient triage, and really improve patient safety and the quality of care. And lastly, that when we look out to the broader community, at least here within, North America, that NICU and community hospital providers seem to find teleneonatology to be acceptable, appropriate, and feasible for their practice as we think about, again, shifting the standard of care for newborns. So I just want to take one moment to acknowledge my colleagues, my fellow neonatologists, who are providing these consults day or night, as well as my friends and colleagues in Connected Care who have really supported the implementation and improvement and growth of our program. And lastly, acknowledging my top-notch, amazing operations manager who keeps our program running with a very high level of performance. So with that, I look forward to our discussion and welcome any questions you might have. Thank you.